Thank you for the opportunity to speak about something that's very near and dear to me. I am a urologic oncologist, but I spend a fair amount of my time thinking about how to make the health system better and behave more rationally. And that's what we're going to talk about today. I've spent the last 6 or 7 years working in value-based payment, trying to change the way that we pay for care so that we can get a better outcome out of the system. And my general thesis is that the way we pay for care right now is the reason that our health system is, let's just say, underperforming. Getting paid on a fee-for-service model discourages care coordination. It discourages people taking ownership of the patient experience beyond when they're right in front of you. And if you've ever been through the system as a patient or as a physician, I think you can understand very quickly that we can do better. And my argument is that if we paid differently, we'd get a different outcome. And so we'll talk about what the different possibilities are for how we can get paid. No financial disclosures, although I wish I did. None to report. So 3 topics I'll speak briefly about, and I'd like to leave time for questions if we can. I'd love to have a dialogue with anyone who's interested. So what is value and value-based payment? Why are we chasing this, and how do we do it? I always start with my conclusion at the top so that everyone knows where I'm heading. Physicians can leverage value-based payment models to drive value for our patients and for ourselves. And this really ties in with the brief preamble that I gave, that the fee-for-service system that we operate under, I think, is in large part responsible for the poor performance of our health system, and that not only could our patients do better if we got paid differently, but that we as physicians could also do better. In addition, this chase for value-based care is well underway. And my message to the people in the room is that we need to be ready for it and figure out how we're going to be a part of it. So what is value and value-based payment? This is the standard textbook answer to what is value. Has anyone seen this equation? Show of hands. Sam, you've seen it. I know for sure. Dr. Lerner, anyone else? A few? So not many. Great. So in healthcare, for about the last 20 years, we have defined value in this way: the outcomes that we achieve for the spend that's required to achieve them. So you can imagine, to achieve higher value, you either need to keep your spend the same and improve your outcomes, or you can keep your outcomes the same but do it on less spend. That's more of an academic approach. It's a helpful model to kind of hang our knowledge on, but I think a more important way to do it is to think about how people have described value in practice. This is from the American Urological Association under the Choosing Wisely campaign. Choosing Wisely is an effort, physician-led, to try to identify what is high-value care. What does it actually look like? What should we be doing? What should we not be doing? And I don't want you to go into details and read these, just to know that there has been an effort from the AUA to identify these things, and many other specialties as well. But for me, I think this is how most of us in our daily lives interact with value-based care. You know it when you see it. This is a famous quote. Some of you may know this from a Supreme Court opinion issued in the 1960s, talking about how do you know when you've seen something obscene. And the official Supreme Court opinion was, I know it when I see it. That was the rule that we used. And I think we know this as practicing physicians, that when you see high-value care, you can recognize it, hopefully in yourself. But more easy thing for you to appreciate is when low-value care walks in the door, right? You've all seen that. You've been a part of that. You've had patients who've been referred in that way. And I think it's important to recognize that we as providers, every day that we make decisions about patients' care, we are creating value. It's value when I decide that I want to send a patient to see palliative care before we go on to cystectomy, so that they can have their post-acute care course more settled. It's valuable when I say no to a patient for a procedure. That generates value. It doesn't generate value for me necessarily, but it generates value for the system. And so I think we know it when we see it, and it's important that we try to capture that. So moving from the concept of value to payment, how do you take that value concept and translate that into payment? Value-based payment is about getting paid to do a better job for your patients. It's being held accountable for those outcomes that we saw in that last equation in the numerator. It's not about getting paid just to do more, which is the system that we operate under in large part today. At Vanderbilt, we are heavily engaged in value-based care, a lot of value-based care contracts. We take a tremendous amount of risk for the populations that we take care of. The way that I communicate this to our physician colleagues is value-based payment is really you taking a bet on yourself. Are you willing to take a bet on the care that you provide to your patients so that we can achieve a better outcome and a better alignment of incentives? So why do we chase this? This, to me, is the most compelling reason. I have another reason that follows this, but for me, this is the most compelling. I think that there's a significant amount of frustration, not only for our patients and how they experience healthcare, but for us as providers. Data supports that. That's very clear, particularly during the pandemic, we've seen that. I have a very personal experience. I'll share it briefly with my father, who was diagnosed with AML in 2016, acute myeloid leukemia, and spent 104 consecutive days in a hospital before he died in ICU, having never seen palliative care during that journey. 104 consecutive days in a hospital. It was like a stress test for the health system, and the health system failed. My dad was never going to survive his AML. He just got dealt a terrible hand. But the way that he experienced his condition through the health system was awful. I mean, I saw so much waste and so much low-value care, and it's really what set me on this journey. So I really think the drive here is to deliver a better experience, both for us as providers, but also for, and most importantly, for our patients. Now, there are other reasons. I have a chief financial officer that I have to answer to in our health system, so I know the other reasons. So there are 3.7 trillion reasons to try to move towards a value-based care system. Anyone know what this number represents? That's exactly right. National healthcare expenditures. Whoever whispered it, I heard it. The number is actually 4.1 trillion in 2020. That was how much this country spent on healthcare. That's about equivalent to the GDP of Germany, the entire economic output of the country of Germany, fourth largest GDP in the world. 3.7 is the money we actually spent on what you and I would consider clinical care, like actually taking care of people, not public health measures, but the clinical care. It's estimated that 30% of this number is waste in our system as a consequence of the way we pay for care. 30%. I was always told, don't do easy math in public, so I won't, but I think you can do it yourself. 30% is a big number. It's a substantial number when you're talking about $3.7 trillion. And so these are all the reasons that not just myself, but, and I'll show you a slide later on, health systems, payers, purchasers, Medicare, Medicaid are all pushing value-based payment because they see it as a tool to try to address some of the challenges I've listed. So how do we chase this? We have 5 minutes. That's perfect. I'll try to finish this quickly and leave some time for questions if we have it. So we have to get the delivery model right. This is key. If you are not delivering the highest value care possible, then the payment model around it is going to fail. You have to have the right delivery model to do that. So are we doing the right things for our patients? And not just in that moment when you see them, but throughout their experience. So if you have patients who have bladder cancer, non-muscle invasive, and they're on intravesical therapy, how are you managing those patients in between their trips to your office? My patients don't get readmitted at a 50% rate from after cystectomy, but someone's patients do. And are we managing those patients appropriately when they get out of the hospital? What are we doing to try to ensure that the delivery model is correct? We have to focus there first. But once we get the delivery model right, then we have to go to the different payment model. And what I want to share with you are the different payment models that are out there. And I'll focus on bundled payments briefly because that, I think, is what's most applicable to us. But you guys have the perfect. So you can see here fee-for-service on the left side. This is considered, the base starting point. And the dream is that we head this direction where we take increasing amounts of risk for populations. These payment models, shared savings, shared risk, global cap, you've probably heard of these. These are more for managing populations. I think what's more relevant for us as specialists is that we are managing conditions or events, and that's where these bundled payments come in. And so what is a bundled payment? Anyone heard of bundled payments? Not for your insurance, like your car insurance, but in general, bundle payments, great. So some folks have heard of that. So a bundle payment, the easiest way I can describe this, it's a single payment for a series or group of services around a related event. So pick an event that people would have in their health care, a maternity event, a cystectomy, a prostatectomy. That event, you would get paid a single price for that event or get held to a single price for that event, but it would include all of the services that go into it. And so you can see here on the slide, on the left-hand side, is that one bundled fee for all of those services. These are just presupposed services, as opposed to fee-for-service on the right-hand side, which has, as you can see, multiple fees. It's less predictable. There's no providers taking risks. No one's taking a bet on themselves on the right side. On the left side, we're taking a bet on ourselves. We're providing a single fee. We've seen bundled payments in action. Medicare has rolled out several bundled payment programs. I was lucky enough to be involved in those. Not all of them proved to be appropriately designed, but here's an example of a total joint replacement bundle. It's kind of the classic example of a total joint replacement. And the way this model worked is that Medicare had a single target price for a total joint replacement and the 90 days thereafter. And hospitals would be held accountable for that single price. This is Vanderbilt Medical Center data. This is actually our data. What you can see on the left-hand side of that gold bar, that's before the program started. And that blue line represents how often were we discharging Medicare patients who had a total joint replacement to a skilled nursing facility postoperatively. How often were we doing that? You can see it's somewhere in the range of 35 to 45%, right? It's around that number. Once we went at risk and we were responsible for the spend that occurred after the hospitalization, we realized we didn't need to be sending patients to skilled nursing facilities. That's the switch in the care model. That's changing the care model. We no longer were sending patients to skilled nursing facilities. And we drove that number down to single digits, and it's held there for the last 5 years. And this experience in driving down skilled nursing facility, you could argue, well, maybe we were withholding appropriate skilled nursing facility care. Maybe someone needed that, and we didn't give it to them, and that's a problem, and I would agree with that. Looking at our readmission rate, it doesn't tell that story. That, in fact, our readmission rate went down. And the reason is because the SNFs, at a hairpin trigger, would send people back to the ER. And so this churn that was occurring was creating zero value for anyone. And that delta that you see from the 35, 45 down into the single digits, that's money that we did not need to be spending. This model changed how orthopedic practice was done nationally. And if you talk to your orthopedic surgeons now, they will tell you, we don't send patients to SNFs, except maybe a 10% rate, the folks that actually need it. It was just a crutch, and it was easy, and it was what we did. And so I think this is the promise that bundle payments can do, value-based payments. At Vanderbilt, we create our own bundle payments. We sell them directly to employers, to the employer community, and we've seen great success in that program. We don't have time to go through that. The last thing I'll show here is that if you look across, this is that traditional fee-for-service, bundles, population-based payment. if you look across different populations, Medicare Advantage, traditional Medicare, Medicaid, commercial, you can see that since 2017, these populations are unloading traditional fee-for-service. That's what this represents here, the delta. Original Medicare is an exception to that. And they are moving more quickly to this right side to try to pick up more value-based payments. And the reason I highlight this is because, as I said before, this is coming. This is happening. Payers, purchasers, employers, they're going to demand this. And I think rightfully so. And I think we just have to be ready for what it looks like and how we do it. So again, we can leverage value-based payment models to drive value for our patients and ourselves. This chase is happening right now, and we just have to be ready for it. So thank you very much for your attention. I appreciate it.